So one more topic we have to cover for our online students is on oncosurgery. Okay, oncosurgery, please come to oncosurgery. So oncosurgery, skin cancers. The most important topic for your exams in oncosurgery is skin cancers. You would have read about skin cancers in your dermatology also. Let me give a basic outline from surgical aspects. So basal cell cancer arises from stratum basal layer. So I hope you know the layers of the skin, layers of the epidermis. Cute looking girl Sangeeta Bijlani is a mnemonic for this epidermis. Cute looking girl Sangeeta Bijlani. Carnium, lucidum, granulosum, spinosum, basalis. So spinosum, basalis. These are the layers of epidermis. So basal cell layer arises from basal cell cancer arises from basalis layer. Squamous cell cancer can arise from spinosum layer or from basalis layer. So squamous cell cancer can arise from stratum basal or from stratum spinosum. But whatever it is, don't forget both of them are arising from epidermis. Both of them are from epidermis. The most common skin cancer in practice is basal cell cancer. Second common skin cancer is squamous cell cancer. Basal cell cancer is called as a tear cancer because it is most common in face along the tear flow area. So when you cry, the tear flows in this place. So this is a common place of basal cell cancer, and basal cell cancer has only local spread. Like a rodent, it spreads only locally. There is no lymph node spread, no hematogenous spread. Therefore, it is also called as rodent ulcer. Don't forget, it is also called as rodent ulcer. Squamous cell cancer of the skin can be divided into many types based on the irritation. Squamous cell cancer means it is usually due to irritation. Gangrene cancer is a cancer seen in the abdominal wall. So this is very common in people in Kashmir. They keep a hard pot on the abdomen. That causes a cancer in the abdominal wall is gangrene cancer. Tibetans sit on with a buttock on a hard pot. So buttock cancer. Chimney sweeper is a scrotal cancer. So squamous cell cancer can be of many regional wise. There are names: gangrene cancer, abdominal wall, cancer in the buttock, chimney sweeper in the scrotum. Among the chimney sweepers, the scrotum gets so much of heat and the scrotal cancer can happen. So don't forget the two common cancers I'm comparing and telling you. So the shape of the ulcer in basal cell cancer is like this. It's a rolled out edge. Whereas squamous cell cancer is an everted edge like this. Everted edge. So squamous cell cancer is a rapidly spreading cancer. It can go local spread is present, lymph node spread is present, blood spread is also present in squamous cell cancer. And basal cell cancer is usually due to ultraviolet light exposure. That is the only reason. Squamous cell cancer also is due to ultraviolet light, but there are so many causes of squamous cell cancer. Radiation, chronic scars forming marjolin ulcer, squamous cell cancer in situ in the glans penis is called as erythroplasia of Curette. In the glans penis, in situ squamous cell cancer is erythroplasia of Curette. Bowen's disease is squamous cell cancer in situ of skin, anywhere in the skin. So skin, Bowen's disease, erythroplasia of Curette, and these are all going for cancer. Human papillomavirus is a very important predisposing factor of squamous cell cancer. Don't forget this. So most common location of basal cell cancer is face, and it is most common in the white people. You can see the typical basal cell cancer. Squamous cell cancer is not only seen in skin. I hope most of you know. It is a skin cancer. It is seen in oral cavity. Where all places you get squamous cell cancer. In the oral cavity, you get squamous cell cancer. Esophagus, you can get squamous cell cancer. Anus, you can get squamous cell cancer. Penis, you can get squamous cell cancer. Vagina, you can get squamous cell cancer. Cervix, you can get squamous cell cancer. And very important, bladder also you can get squamous cell cancer. So many places you get squamous cell cancer. Squamous cell cancer is very common. It is mostly due to irritation. So all these are various places you can get squamous cell cancer. So we are discussing a chapter on skin squamous cell cancers. Other things we have discussed in corresponding chapters, go through that. So now coming to the types of basal cell cancer, the most common type is nodular type. Okay, nodular type, superficial spreading type, and cystic form. Superficial spreading is a very interesting type. It spreads like this with a central healing. There will be a central healing and surrounding is burning. It is like a field fire. Like a field fire, central clean, central healing, peripheral burning. So looks like a field fire. This is called as field fire type. Field fire type. This is a typical basal cell cancer. Nodular type is a commonest. This is a picture showing you a nodular type. You can see a typical nodular type is a commonest basal cell cancer. Ulcerate, this squamous cell cancer will have a proliferative cancer. It's a proliferative lesion. One type of squamous cell cancer is called as verrucous cancer. Verrucous cancer is a type of squamous cell cancer. Marjolin's ulcer is a type of squamous cell cancer in the skin. These are all seen in the skin. Verrucous, Marjolin's are all squamous cell cancer. So don't forget the mode of spread is only local spread, no lymph node, no hematogenous in basal cell. All spread is seen in squamous cell. So this is a pathology question. In a peripheral smear, there is a peripheral palisade appearance. On biopsy of the basal cell cancer, the cells are arranged like a peripheral palisade pattern like this. And this finding is called as, what is this? Basal cell cancer, the finding is peripheral palisade pattern. What is the squamous cell cancer finding? This is called as keratin pearl. This is a repeat MCQ from pathology. Keratin pearls are seen in this typical squamous cell cancer. So margin of the cancers is just 4 to 6 millimeter margin is enough for both basal cell cancer as well as squamous cell cancer. A very small margin is enough. 4 to 6 millimeter margin is enough for both the cancers. And a new update is there called as Mohs micrographic surgery. It's a cosmetic surgery, especially in the face, penis and all. You do this. It's a serial excision. Serially, you have to excise the tumor. Serial excision of tumor until you get a negative margin. So until negative margin obtained, you excise the tumor slice by slice by slice. That is called as Mohs micrographic surgery. So this is a typical picture showing you a Marjolin's ulcer arising from a long-standing scar. Marjolin's ulcer. So it can arise from burn scar. It can arise from keloid scar. It can arise from any chronic venous ulcer scar. Any scar, in fact, any old scar will get Marjolin's ulcer. Since the lymphatics are obstructed, there is no lymph node spread. In the Marjolin's ulcer, there is no lymph node spread. Please don't forget, because the lymphatics are getting obstructed, there is no lymphatic mode of spread. So lymphatic spread is absent in Marjolin's ulcer. It's a type of squamous cell cancer. It's a repeat image-based question. So don't forget Marjolin's ulcer. These are the two common cancers, basal cell and squamous cell. And the most notorious skin cancer is melanoma. And why it is notorious? Because it is common in young girls of your age group between 20 to 30 years. It's most common skin cancer in females of age group 20 to 30 years. 20 to 30-year females, the commonest cancer is melanoma. That much it is a common cancer. It is having high mortality. It is due to sunlight, xeroderma pigmentosa, and a dysplastic neva is nothing but a normal mole. What you have, the mole. Dysplastic neva or family history. All these are various causes of malignant melanoma. And melanoma has the typical 5 features. Bailey and Love gives A, B, C, D. A for asymmetry of the mole. If there is a mole, if it is looking asymmetrical, if it is asymmetrical like this, the border is irregular, border irregularity. Color variation. There is a color variation. Diameter more than 6 mm. or the tumor is having evolution. It is increasing. So diameter more than 6 mm, evolution, border irregularity, color variation, all these are clinical features of melanoma. And there are following features of melanoma you are seeing here. Superficial spreading type is the most common type, which is 70%. Like this. You can see the picture of superficial spreading type. Please don't forget it arises from pre-existing mole. The mole you have in your body will go for this pre-existing nevi. So the moles, if you have a mole somewhere, it can go for superficial spreading melanoma. It is having good prognosis because it is only superficial spreading, no deep spread. It is only spread superficial, no deep spread. So therefore, it is having a good prognosis. And in females, it is common in lower limb. It is common in lower limb in females. In males, it is common in trunk. So in males, it is common on the chest or on the back. In females, it is common in the lower limb and the upper limb. Extremities, it is common. So whatever it is, superficial spreading melanoma has a good prognosis. Nodular melanoma is very dangerous because this is a melanoma which is when happens like this, it will not spread laterally, but it spreads deep like this because the prognosis of melanoma depends upon the death. So more deep invasion, so there is a bad prognosis. Nodular melanoma is second most common. It is common in the head and neck and it has bad prognosis. Lentiga maligna melanoma is most common in old females. It is called as Hutchinson's freckle. Another name of lentiga maligna is Hutchinson freckle. It is least common, least malignant melanoma. So don't forget, lentiga melanoma is least common, least malignant. So malignant melanoma is always seen in white people. Please remember, malignant melanoma is seen in white people. The most common melanoma in black people is acral lentiginous. Most common melanoma in black people is acral lentiginous, and even in black people, it is seen in white areas. Most common in palms and soles. Even in black people, where is it seen? It is common in palms and soles. So most common melanoma in black people is acral lentiginous, and in acral lentiginous, it is common in palms and soles. Okay, don't forget this. And subungual melanoma is a melanoma seen below the nail bed. Below the nail buds, it is seen. For example, this is a nail bud. Below the nail bud, there will be a blackening which will produce pigmentation like this, called as Hutchinson sign. Hutchinson sign is a pigmentation in the nail fold. So don't forget, subungual means below the nail. Amelanotic melanoma is a worst prognosis because it does not have pigmentation and it is missed many times to diagnose. It is having worst prognosis. So most important question for exam, prognosis depends on depth. So don't forget this MCQ. Prognosis of the melanoma depends on depth. That is why nodular melanoma grows inside as worst prognosis. It grows more and more deeper. If there is an ulceration, it is bad prognosis. If there is a lymph node, it is bad prognosis. Extremities have good prognosis. Trunk have bad prognosis. Males getting a melanoma is bad prognosis. Females is good prognosis. Histology, superficial spreading melanoma is good prognosis. Nodular is bad prognosis. This is a repeat MCQ. What is the prognostic factors? Depth of infiltration is the most important prognostic factor. So don't forget this prognosis of the melanomas and the various points. So whatever we discussed in basal cell cancer and squamous cell cancer, they are very mild cancers. Nothing to worry, nothing will happen to them. For example, if this is a basal cell cancer like this, how I am going to operate is, I am going to do most micrographic surgery. So take a slice blade and slice it. Slice number 1. Slice it number 1, 2, 3, 4. You keep on slicing until you get a negative margin. So by doing this slicing operation, I am preserving the penis. Otherwise, what will happen? I would have to cut the penis, giving a 4 to 6 millimeter margin. Now I'm not going to give that much margin. I will cut until I get a negative margin. That is called as most micrographic surgery. So most micrographic surgery is not a big task. Just remember, most micrographic surgery is a slicing surgery. Until you get a negative margin, it can be done for squamous cell cancer and basal cell cancer in a cosmetic areas where you want organ preservation. I want to preserve the organ preserving surgery. Okay. So just remember, it cannot be done for melanomas. Most micrographic surgery cannot be done for melanomas. So melanomas, the prognosis depends upon the depth of invasion called as thickness. So Breslow's thickness and Clark's thickness. There are two types. Breslow's thickness is on millimeter of depth. So it would have been done with the help of MRI, probably with the help of MRI. They calculated the depth of invasion. So less than 0.75 mm depth, 0.75 to 1.5 mm depth, 1.5 to 3 mm depth, 3 or more mm is this level 4, more than 1.5 to 4 mm depth. Okay, it is up to 4 mm depth. More than or equal to 4 mm depth is level 4. Remember like that. Level 4 is 4. 0.75, 0.75 to 1.5, 1.5 to 4, more than 4 mm depth. Or you can go for the layers according to the layers. This is epidermis. This is a papillary dermis. This is reticular dermis. And this is subcutaneous fat. So if the tumor is involving epidermis, level 1, papillary dermis, level 2, junction of papillary and reticular dermis, subcutaneous. So level 1, level 2, level 3, level 4, level 5, based on the layers is called as Clark's, thickness is called as Breslow. Can you tell me the tumor marker of melanoma? HMB45 and Milan A. Two tumor markers are there. And for melanomas, I cannot give a small margin. I have to give a 1 to 2 centimeter margin. And that too three-dimensionally. Three-dimensionally, I should give 1 to 2 centimeter margin. Therefore, there will be a very big gap. So after surgery, there will be a very big gap. 1 to 2 centimeter margin needed for melanomas. Three-dimensionally, I need that margin. Okay. And you should not forget what is this. What will you do about the nodules? Let us assume this is a melanoma. Okay. Let us assume this is a melanoma here. Let us assume this is a mole in the malignant melanoma in the lower limb. Now there are two nodules. If there is a nodule along within 2 centimeters, it is called as satellite nodules. Or if there is a nodule along the lymphatic more than 2 centimeters, it is called as in transit nodule. So nodal spread is very common. So as it is going on, for example, if this is a lower limb, this is a lower limb. I told you it's very common in lower limb. No? So let us assume this is a malignant melanoma. It can spread within 2 centimeters. It is called as satellite. It can spread along the lymphatic spread. So anywhere along the lymphatic spread is called as in transit. So we will in centimeter less than 2 centimeter or more than 2 centimeter, you call it as in transit nodules or satellite nodules. If there is such full lower limb having so much of nodules, a new treatment shown in the picture is used. What is this treatment? This treatment is called as isolated limb perfusion surgery. Because I cannot go and remove the entire lower limb. No? So I can going to preserve the lower limb by a surgery called as isolated limb perfusion therapy. If you very closely observe this, you can see I have clamped the femoral artery and femoral vein, and into the femoral vein, femoral artery, I am pouring a chemotherapy. And now it is remaining in the lower limb and it is coming out through the veins. No, I am taking out instead of allowing it to go into the systemic circulation, I will take it out. So therefore, only lower limb, this entire lower limb is getting circulated by a chemotherapy, not at all going into the abdominal cavity or anywhere else. Chemotherapy goes inside, chemotherapy taken outside. So it is in a circuit, it is taken out. I am perfusing the lower limb with a chemotherapy called as melphalan. This is called as melphalan chemotherapy. Don't forget. So this is therapy is called as isolated limb perfusion therapy. It is used for isolated lower limb involvement. There is no metastasis, nothing, only lower limb involved. I will go for this isolated limb perfusion therapy. So don't forget this point. And this is a picture showing you the classical, what is this? Chemoport device. I hope you remember this. This is a question very commonly asked in AIMS exam. Chemoport device. We keep it subcutaneously. I can inject every time chemotherapy directly into this silicon sheath. I can inject and take drugs and all through this. So chemoport device for delivering chemotherapy into the central veins. It is like a central lumen catheter. I want to put the chemotherapy directly into the central veins. I use this chemoport device. So don't forget these basic points for your exams from skin cancers. And finally, to complete oncosurgery, I will give a basic outline of pediatric oncology. This is a pediatric surgery OP guy question. Please answer this question. Most common cancer in childhood is, what is the most common cancer in childhood? It can be leukemias. Leukemias is the most common cancer in the childhood. Okay, very good. Yes, leukemias are the most common cancer in childhood. Second most common tumor or the most common solid tumor is brain tumor. So we have discussed in neurosurgery, I told you it is grade 1 pilocytic astrocytoma, most commonly located in the cerebellum. In children, the brain tumor is commonly located in the posterior fossa, also called as cerebellum. Most common abdominal tumor, also I told you, most common abdominal tumor or most common extracranial solid tumor is neuroblastoma. And neuroblastoma is a serious problem in the babies. It is the most common tumor overall in children less than 1 year. So less than 1 year, the overall common tumor is neuroblastoma. And most common soft tissue sarcoma is rhabdomyosarcoma. Rhabdomyosarcoma is sarcomas are also very common in children. So most common renal tumor in children, most of you might be answering Wilms tumor. No, there is one more tumor called as mesoblastic nephroma. Wilms tumor is second common. So which tumor is very dangerous in children? Please remember, it's neuroblastoma, which produces metastasis to lung. Neuroblastoma is equivalent to pheochromocytoma in adults. Adults pheochromocytoma is equal to neuroblastoma in the children. Neuroblastoma originates from the adrenal medulla. It arises from the adrenal medulla. So don't forget, neuroblastoma comes from adrenal medulla. It is equal to pheochromocytoma of the adults. Very important topic, pediatric oncology. Just go through this. Common tumor is leukemias. Most common extracranial tumor is neuroblastoma. Most common tumor less than 1 year is neuroblastoma. Neuroblastoma is a tumor with a lot of mets. This is from the oncology point.